I need to plug my computer in. And you know what? I have to pee. So let's take a couple minutes, like 5 minutes, because I have to run to the bathroom, and then let's get started, okay? Miss Fia, your Nurse Ratched is freaking me out. It's from the show Nurse Ratched on Netflix. I just rewatched it. I don't like it. I don't like how she's moving her head.
I just texted her that.
Freaking me out. All right. Everybody is ready. Yes? Let's do it. The respiratory system. Okay. Why is this? What? Why do I hear Christy Bowling's voice? Don't like that. She must have recorded this for some reason. Okay. Anyways. All right. So for the respiratory system, we have respiratory review. We're going to go over COPD, acute respiratory distress syndrome, which is also known as ARDS.
We
Acute
can't see your
respiratory.
we
We
can't see
can't
the
see your
slides
screen.
anymore.
Oh, okay. Stop. Oh, this is frustrating. Okay. Can you see my screen? Okay. Acute respiratory failure, which can also be seen in like charts and things, is ARF. Pulmonary arterial hypertension, pulmonary embolisms, chest trauma, pneumothorax versus hemothorax, chest tubes, and artificial airways, intubation, mechanical ventilation, and I believe also trachs. So the respiratory system is composed of the upper and lower respiratory tracts, blood vessels, the thoracic cage, the spine, ribs, sternum, respiratory muscles, and the diaphragm. We need a functioning diaphragm to be able to breathe. Okay. Respiration requires ventilation, which is the movement of air from the atmosphere to the alveoli. The alveoli is where gas exchange occurs. Okay, so we need to think back to our anatomy and physiology days. We see those little alveoli bubbles at the end of the bronchioles, which is where our gas exchange occurs. So diffusion, which is exchange of the oxygen and carbon dioxide at the alveolar capillary membrane. Okay. Perfusion is blood flow. In addition, innervations of the respiratory system are controlled by the neurological system and the muscular system. So the brain, the medulla, the pons, and the spinal nerves are responsible for respiration, but also the diaphragm and the intercostal muscles. What are intercostal muscles? What does intercostal mean? Inter means between the ribs. It is the muscles between the ribs, yes. And then chemical regulation, which is going to be your gases. So there's a difference between your upper respiratory tract and your lower respiratory tract. The nose warms, humidifies, and filters the air. And then you have your sinuses, which are air-filled spaces that produce mucus to keep the nose moist. Love getting bacteria in there. So fun. Then you have your pharynx, which is the passage of food and air to the lungs and digestive system. Your larynx, which contains the vocal cords and epiglottis. Your vocal cords produce sound for speech, and your epiglottis covers the vocal cords during swallowing. If the epiglottis does not work, there is a huge risk for aspiration, which is why when someone has swallowing difficulties, it really means that they've lost that control, the muscular control of their epiglottis, which is not covering their airway well, and what causes aspiration can be a cause of aspiration. Okay. The lower respiratory tract includes the trachea, which is the tube that carries the oxygen into your lungs. You have your bronchi, you have your main stem, and then right and left bronchi. And then that goes down into the bronchioles. So you have the main stem bronchi, right and left, and then down into the bases of the lungs, the bronchi get really, really small, and that's what we call bronchioles. And then, of course, we have the lung tissue that expands and contracts when we inhale and exhale. We have our diaphragm, which is down here, and it is a very large muscular feature that has the ability to go up and down for your lungs to contract and relax. And then we have the alveoli, which are air sacs where gas exchange occurs. Do you remember there's a word, it starts with an S, and it is responsible for lubricating the alveoli? Yes, surfactant.
Surfactant.
Surfactant, yes. That just made me so happy. All right, so steps of gas exchange. So we start with ventilation. It's the act of breathing in and out, right? We inhale oxygen, we exhale CO2. It goes down into the alveoli and diffuses into the capillary membrane. And this is where the exchange of oxygen and CO2 occur. Okay. And then we have the circulation where our body transports that oxygenated blood all the way up to the brain, to our vital organs, to the rest of our body. Okay. And then at the end, well, it's really just a continuous circle, is cell exchange. The fusion of oxygen and carbon dioxide takes place on a cellular level. So that diffusion of oxygen and CO2 doesn't only happen in the alveoli and capillary beds, it also happens to oxygenate our cells. Okay. So this picture zoomed in, this is your alveoli, this is your capillary membrane, and this is the diffusion happening between the two. Okay. We ready to move on? I didn't know how much fill-in stuff you have, but a lot. Yeah, it is small. Every time I go into like presentation mode, she starts talking. You know what I'm gonna do? I'm gonna put down volume. See if I could share. There we go. A little bit bigger. And I think you can zoom on your screen, right?
Some papers that's writing.
Oh, the paper is small.
That's what ours looks
Oh, I understand. Okay.
like.
Do you need a light on?
No, it's good. It's just. It's. Right.
And I think it's helpful too to share the PowerPoint like after the fact. Like I like that you guys have the ones that you have and you're writing it and you're remembering it from writing it, but I don't mind you also having the other one that's like filled in. But I'm not giving it to you beforehand because I want you to write it out. Yay, ABG review. Yay. We knew it was coming back, right? Oh, I couldn't wait. Okay, so this measures the balance of oxygen and carbon dioxide in your blood to see how well your lungs and in retrospect, your kidneys are working. So what is our normal pH?
7.35 to 7.
7.45. Jade, I can always count on you. What is our normal PaCO2? And when we do our
35
little
to 45.
diagram, what do we need to do with it? Flip it.
Flip it.
Flip it. Oh, it just
Flip
changed. And then our normal HCO3, which is our bicarb, is what?
22 to 26.
So when we're looking at this blood gas right here, is our oh, it's not even giving us numbers. It's just giving you the steps. So you remember we're going to determine what our pH is. Is it normal? We're going to put it in the middle. If not, we're going to put it to the side. If the CO2 is normal, we'll put it in the middle. If not, we're going to put it to the side that it belongs on. If the bicarb is normal, we're going to put it in the middle. If not, we're going to put it to the side. So if let's see if it goes into our. So for respiratory acidosis, our CO2 is high. Our pH is down. Because if we're acidic, that means our pH is less than what?
7.35.
7.35. Good. So causes for respiratory acidosis can be anything that causes respiratory depression. So droughts, increased intracranial pressure, sleep apnea, and then also anything that impairs gas exchange. So COPD, pneumonia, trauma to the chest wall, as in a pneumothorax or hemothorax, and then also a PE. So your symptoms when you become more acidotic, or these symptoms can actually cause you to go further into respiratory acidosis. So altered consciousness, a decreased blood pressure, decreased respiratory rate, hypoxia, and then respiratory acidosis can cause dysrhythmias. There's a little box here, which makes me feel like it's important, but it's hard to read. To compensate for acidosis, hydrogen ions move into the cells to lower the pH. This causes potassium to leave the cells and enter the blood, causing hyperkalemia, which causes your dysrhythmias. So for your treatment, you want to administer oxygen, suction secretions, turn the patient, cough, have them deep breathe, antibiotics if needed. What this is missing is that when patients become severely respiratory acidotic and they are not compensating, like if you have a patient with a drug overdose, if you have a patient that has a COPD exacerbation that is in severe respiratory acidosis, they are confused. They are not doing well at all. What you need is a BiPAP. Okay? Because what a BiPAP does is it forces oxygen in, but it also forces CO2 out. So putting oxygen on a patient that is in severe respiratory acidosis is not going to do anything for them. They're just, yeah, I mean, they're breathing, they're oxygenating, but the problem is that we need to get the CO2 off. Does that make sense?
It works.
Yes. So, and one step further, ventilation, mechanical ventilation does the same thing. So if your patient is intubated, this is also forcing inhalation and forcing exhalation. Okay. So in the severe cases, you have to force that CO2 out to correct the acidosis. Okay. So then we have respiratory alkalosis. So that means your pH is high, your CO2 is low. This is from hyperventilation. You're blowing off all of your CO2. You got no CO2. Remember, CO2 and hydrogen ions mean the same thing. Hydrogen and CO2 are what cause acidosis. Okay? So this can be caused from anxiety, pain, a fever, asthma, a PE, aspirin toxicity, mechanical overventilation. So if the settings on the ventilator are too high and they're breathing too much, too fast, not holding on to enough CO2, they will become alkalotic. So your symptoms are increased respiratory rate and depth, an increased heart rate, confusion. And then again, we look at this and it says to compensate for acidosis, hydrogen ions move out of cells to increase the pH, causing potassium to enter the cells and leave blood, causing hypokalemia. That hypokalemia is responsible for your dysrhythmias. So for treatment, we want to have breathing techniques to slow down the breathing. Breathing into a brown paper bag. What is something we talked about last month? What if we don't have a bag? We breathe into cupped hands. This is your own personal bag here. Okay. Supplemental oxygen, anti-anxiety medications, and analgesics for pain. So when we are saying supplemental oxygen, this is something we also have to be careful with, just like our previous slide. We don't want to over-oxygenate because we want to hold on to the CO2. We need to correct the respiratory alkalosis by holding on to carbon dioxide. Does that make sense? So now we have metabolic acidosis. So we've moved on to the what organ system? What organ system is responsible for metabolic? The kidneys. Thank you. So, the causes are anything that causes increased acid production. So malnutrition, which causes a breakdown of fats and increase in ketones. We have DKA, which is also ketones that build up in the body. We have sepsis with increased lactic acidosis. Alcoholism. And then anything that causes decreased acid excretion. I'm sorry, I thought it was saying it the other way around, and I'm like, that's not right. So decreased acid excretion. So your kidneys are holding on to too much because you're in renal failure, because you have an AKI, because you have CKD, right? So the kidneys are unable to excrete that waste that's building up. And the acids are just building up, and the bicarb cannot compensate. And then also anything that causes excessive bicarb loss, which could be severe diarrhea. And it says, remember, bicarb comes out of your base. Base, meaning butt. So your symptoms are going to be your Kussmaul respirations, which we see in what disorder? DKA.
DKA,
Yep. Decreased blood pressure, confusion, hypoxia, hyperkalemia, which can cause what?
dysrhythmias,
Dysrhythmias, thank you. Your treatment is going to be electrolyte correction. Initiate seizure precautions and monitor the respiratory status. So now we have metabolic acidosis. This is caused by anything that causes excessive loss of acid, like vomiting or excessive GI suctioning. Anything that causes excess bicarb. So if the patient receives too much sodium bicarbonate, if they are drinking an excessive amount of alkaline things that include antacids, milk, and baking soda. So these are all bases. These all neutralize. Hyperaldosteronism. It causes sodium and hydrogen exchange in the kidneys, which cause hydrogen going down and bicarb going up. Loop diuretics also put us at risk for metabolic alkalosis because it causes the kidneys to release hydrogen. Hydrogen is what? Hydrogen and
CO2.
carbon dioxide is what? I just said it. Acid. If you have less hydrogen, less carbon dioxide, you have less acid. If you have more of either of those, you have more acid. The symptoms include a decreased respiratory rate, hypokalemia, lethargy, irritability. What is tetany and the Chaux-Stex from? What
magnesium, decrease in
calcium? Calcium. So this is also causing a disruption in your calcium ions. Your treatment would be antiemetics because we are treating the underlying cause here, stopping the vomiting. Electrolyte replacement, IV fluids, Diamox. Diamox is a diuretic that promotes the loss of bicarb through urination. What is another thing that we can do to treat an underlying cause? If you look at the list of causes. How about stop suctioning?
Right.
Stop GI suctioning. Ready? Oh, apparently we have a break. I think it's so funny that she built in breaks to her PowerPoints. I need to go take my meds now, guys. All right, let's take a 10-minute break. It'll be our last one. Well, 1 o'clock.
Can you go
2:30.
back to the last slide? Sorry. Thank you.
Mm-hmm.
Miss Simmons?
Yeah.
Can you go up one more slide?
Back.
Yeah, just one more up. Yes. Thank you.
Mm-hmm.
Okay, I got
Okay. You guys know the dancing lady in Poland?
Yes, I freaking love her.
Carrie,
That is like one of my favorite person.
you know the dancing lady Keeks in Poland? My brother just sent me a
Yeah, I've seen
Snapchat of her.
her. She like an older lady.
You see it?
I used to talk to her all the time.
Well, that just makes
She's
you
so
crazy.
nice. She's so nice.
I believe that.
She just do that in her spare time.
Dude, she does it
Yeah,
every
she's
day.
just so nice. She does it every day. She used to come
Yeah.
She can do that for some money.
at Raphael, she used to come there and she would hand out like these little cards with like positive affirmations on them, and she's just really nice.
I don't understand how she has that much energy. I wish I had that much energy.
Mhm. She's a teacher.
Is she?
Mhm.
Where?
That I don't know, but I know she's a teacher.
Hmm. Boy. I don't know what time I told people to go. Do you guys?
Like when
5?
should be 3, but it might be 5.
Oh.
I never went, so I don't know.
Miserable. Sad and some. Sweet. Us can't see each other. I don't think they're gonna visit us today. Hey, good riddance. I'm so looking forward to answering the simplest of questions.
They came yesterday. They were like in the classrooms yesterday. But they're doing like clinical site visits today.
Oh, good. I'm glad that's happening.
Was it just yesterday and today? Yesterday and today they were here. They're going to Niles this afternoon. And then tomorrow they go to Sylvania, Cincinnati, and Dayton. But everything has gone really well. So. No, they'll be gone by then.
We're getting scared.
Will you close the door?
We were told that they're supposed to come to our clinical site this week.
So you're going to be on your bestest behavior.
We always are. We are very professional on our site.
Good. Okay, let's keep going. Okay, so obviously, let's not start writing yet. Let's listen. Obviously, we just went over ABGs. We just went over all the respiratory alkalosis, acidosis, metabolic acidosis, alkalosis. So I would hope that you would assume that we are going to have to practice our ABGs and we are going to see them on our next exam. Okay? I believe there's another practice worksheet on Brightspace, I think, for week 2. If not, I will supply it, but I'm pretty sure there is. Okay, so acute respiratory system or syndrome, ARDS. ARDS sucks. ARDS is what did everyone die from COVID? Yes, but COVID caused ARDS, and that's why the patients died. People that die from the flu causes ARDS, and that's why they die. Okay, so ARDS is a life-threatening lung disease that causes severe damage to the alveoli due to inflammation and pulmonary edema. It is not a primary lung disease. It is a complication from a systemic injury that causes widespread inflammation, damaging the alveoli. So you have an acute situation like the flu, like COVID, like pneumonia. It causes damage to the alveoli and capillary beds. There is decreased gas exchange because of that damage. It causes widespread inflammation within that lung space, and oxygenation is no longer capable of occurring. Okay, so an indirect cause is injury outside the lungs, like sepsis, pancreatitis, a drug overdose, burns. This is going to be the least or less likely causes. The more likely causes are going to be your direct injury to the lungs: aspiration, chest trauma, drowning, inhalation, viruses. Okay, so infection injury causes severe inflammation. That inflammation causes buildup. That buildup of fluid in the capillary beds leak into the alveoli, causing a decrease in oxygenation. So the lungs become damaged. The way that your body diffuses oxygen and carbon dioxide is completely damaged and no longer compliant. Okay. Geez, it just get, apparently when you add a recording, as soon as the recording is done talking, it just goes to the next slide. So we understand that ARDS is caused by an injury. It is not primary. It is the secondary problem that occurs because of the first injury, infection, viral infection, and it causes a decrease in gas exchange. Diagnostics, we have a chest x-ray. On the chest x-ray, so we've all seen chest x-rays, yes? The lungs are usually black with white little squiggly lines through them, okay? And those are really just like your bronchioles, your little vessels, but most of it is black. When you have a chest x-ray for a patient that has ARDS, it is a complete whiteout. Both lungs are completely white. And that is caused by fluid accumulation. The more white you have in a chest x-ray, the more fluid you have in the lungs. Okay. You also want to get some ABGs because you want to evaluate your acidosis, alkalosis. You also want to evaluate what is our oxygen saturation? What is our level of carbon dioxide? Okay. Blood cultures and bronchoscopy. A bronchoscopy, somebody saw a bronchoscopy. Jade, did you write about it? Who wrote about it? On
It
their
wasn't me.
clinical paperwork. Who wrote about a bronchoscopy? Luna?
I think it might have been me.
Abby? Okay. So you guys got to see a bronchoscopy during clinical. The patient was intubated, yes?
He had one, I think, in 2014. He was having complications from it, and he had fluid buildup in his lungs. It caused him to become septic.
No, somebody did.
I
Kiara,
wrote
you
about
saw
a
it.
bronch.
Yes,
I
see,
wrote
I
a
knew it.
yeah.
And it wasn't me then.
Okay, so Kiara, you saw a patient that had a bronchoscopy. Was he intubated? He or she?
She was intubated. Yes.
She was intubated, yes. Okay.
Mhm.
So, did you see a lot of mucus buildup?
The doctor kept saying, here's the mucus plug, and then she would squirt the saline or whatever
Yeah.
that was in there to clear it out.
So, what happens is, and when we're talking about mucus plugging, the mucus is so thick that it doesn't matter. I don't care how hard you cough, it is not coming out. And when that mucus plugs off the bronchioles, it stops that bronchiole and the alveoli at the end of that bronchial stem to be able to oxygenate. Okay? So mucus plugging is it has to be removed, and the way that we remove it, there's a couple ways. We can do chest percussion. Have you guys ever seen a chest vest? The chest vest, they wrap around and it goes and it shakes them real like a lot. That helps break up mucus. If you do percussion on the chest, that helps break up mucus. If you really can't get it out and your patient needs a bronchoscopy, 9 times out of 10 they're going to be intubated, and we use saline into the lungs, which you think, oh my God, that's scary. Why would we put water in the lungs? But they don't drown, thankfully. They suck that water back out. Okay, so they put the water in, it liquefies that mucus a little bit more, makes it less thick, so it's easier for the patient to cough out, and it's easier for it to be sucked out with suction. Okay. So we have 3 phases of ARDS. You have the exudative phase, which occurs 4 to 7 days after the injury. It's damage to the capillary membrane, leading to pulmonary edema. Then you have decreased surfactant, which leads to atelectasis. Atelectasis is alveolar collapse. Okay. If your patient has atelectasis, gas exchange is interrupted. Okay. If your alveoli are collapsed, they cannot do or have any gas exchange. So hyaline membrane starts to develop and leads to decreased lung elasticity. This is what makes the lungs stiff. You have refractory hypoxemia, which is a hallmark sign of your exudative phase, and it's low blood oxygen levels despite receiving high amounts of oxygen. And then, of course, obviously, we have shortness of breath. And that would be the earliest sign. Proliferative is 7 to 21 days after injury. This is initiation of lung repair and resorption of edema. Some patients recover at this phase, and patients that do not recover, the lung tissue continues to become more dense and fibrous. We have decreased lung compliance. When we say decreased lung compliance, that means the lungs are not moving during inhalation and exhalation. So the lungs continue to become stiffer and worsening the hypoxia. And then we have the fibrotic stage, which occurs at 3 weeks, greater than 3 weeks after the injury. This is extensive lung scarring. Lungs are very hard and stiff. The alveoli lose inner infrastructure, which worsens the gas exchange, lung compliance, and hypoxia. And at this point, we have a very poor prognosis. The patient is ventilator dependent at this point with a very low chance of recovery. This is where we found our COVID patients at the end. Okay. Before COVID, we saw ARDS with the flu a couple times a year. And then when COVID came, specifically in the Mahoning Valley, when we got hit really hard with COVID, all 29 beds in our ICU patients were dying of ARDS. Okay. Which was not normal. Your treatment includes antibiotics, corticosteroids, diuretics, inhaled vasodilators, oxygenation, high flow BiPAP in the early stages. When a patient hits ARDS, mechanical ventilation is pretty much a given. It's going to happen. Prone positioning. Why? Why did we put our patients in COVID or ARDS in a prone position? What did that do for them?
Relax the lungs.
No.
Just say, it's out.
No. Kind of. So when you put a patient on their stomach, in a prone position for ventilation, they're actually able to, because if you picture the lungs in your brain, okay, where is the most surface area and the biggest parts of the lungs? The back of the lung tissue. Okay. So if you're laying on your back and your lungs are expanding this way, there's only so far it can go. If you lay on your stomach, you have more expansion in the lung tissue than you do if you lay on your back in a supine position. Yeah.
It was one of the guys in ICU that got into shadow. He was on the bed, but they were on him like 17 hours a day. She
Yeah.
did say that. I couldn't remember why.
Yeah, it promotes oxygenation. It does allow movement of mucus from the bases of the lungs. Absolutely. Positioning is huge when it comes to helping someone breathe, moving around that mucus so it's easier to move around, so you can that the oxygen or the blood and oxygen can get to the alveoli, because if the alveoli is just covered in mucus, there's no gas exchange occurring. And then we can also do ECMO. ECMO is one of the scariest things I have ever seen. I hate it. I do not like taking care of an ECMO patient. I will help my friends, but I do not want to be one-on-one with an ECMO patient. Why? Because they have garden hoses coming out of their necks. Literally. They have a catheter the diameter of a garden hose that goes into their arteries, into their jugular vein, and I believe the carotid, I think. And there's 2 tubes, and one takes blood out, oxygenates it, and then the other tube brings blood back in. Okay, so the purpose of ECMO is that the lungs are no longer breathing for you. The machine is oxygenating the blood. So it gives the lungs the ability to rest, relax, and hopefully heal. We did have a very small percentage of successful ECMO COVID patients. ECMO is a Hail Mary. Yeah. Nursing interventions most likely requiring ICU care. Absolutely. Once your patient requires a very high amount of oxygen, they pretty much have to go to critical care. Close monitoring, vital signs, breathing pattern, ABGs and labs. You're most likely going to have an ART line where you can get ABGs and labs very easily. Strict I's and O's. Supportive care. Even if your patient is prone, you still have to offload them. Okay. Tube feeds are started early. DVT prophylaxis and then ventilation weaning when appropriate. Most of the time during your really intense phases of ARDS, you are 100% FiO2 on a ventilator. Okay, so then we have acute respiratory failure. This is sudden and life-threatening deterioration in gas exchange. So when oxygen and carbon dioxide can't keep up with the exchange of oxygen and carbon dioxide during cell exchange, acute respiratory failure occurs. So the patient becomes hypoxemic and the PaO2 drops to less than 50. And then they also become hypercapnic, which means the CO2 is greater than 50 millimeters of mercury and the pH is less than 7.35. So your cells are demanding more oxygen than your lungs can give them. Your lungs cannot keep up with the oxygen demand of your cells. Okay. So your symptoms, we have early symptoms, we have progressive stages, and then we have final. So in our early symptoms, we have restlessness, fatigue, headache, dyspnea, mild tachycardia, mild tachypnea. So this is your body's first response to being hypoxic. Okay. When hypoxia gets worse and hypercapnia, which is an increase in carbon dioxide, gets worse, your symptoms progress to confusion, lethargy, tachycardia, cyanosis. See how it says central cyanosis? Central means the central of your body, the core of your body. Diaphoresis and respiratory distress. And then the final stages is respiratory arrest and death. So when you have a patient that's in acute respiratory failure, it is really, really important to diagnose and start treatment in the early stages. So your nursing interventions would be in the ICU, ABGs, pulse oximetry, vital signs, oral hygiene, range of motion, skin care, DVT prevention, skin breakdown prevention. So this is a patient that's requiring total care. Okay. Oxygen therapy, which is managing the mechanical ventilator, emotional and psychosocial support for the family. Do we talk to our intubated patients? Yes. Always. Always, always, always. We have extremely well documented cases of patients that are intubated, sedated, going through a very traumatic event in their lives that have memories from their medically induced coma where they are sedated on a ventilator. We know that they can hear us. Can they remember it? Do we know how they're processing it? No, I don't know. But if there's a chance that a patient is remembering it, we need to treat that person like they are a human and not just a sack of potatoes that we have to move around and not speak to. Okay? Your treatment is to correct the underlying cause to restore the gas exchange. You need supplemental oxygen, most likely mechanical ventilation. And then, of course, if your patient is in acute respiratory failure because of an opioid overdose, you're going to need some naloxone. Okay. Okay to move on? Okay, back to ABGs. This is something that we skipped over last month. And remember, we said we were going to add to it this month. So this is called a PF ratio. The PF ratio tells the inspired oxygenation that the patient is receiving. This means it helps determine if the patient is getting enough oxygen from the supplemental oxygen on every breath in. So this is how you wean a patient off of a ventilator, by evaluating their PF ratio. How much oxygen, what is the percentage of oxygen in room air? Oh, she's so close. 21.
What do you mean, minimal? Oh, I'm
I'm
sorry.
very correct.
That's okay. The amount of oxygen that is in the air right now, room air, circulating in the air right now is 21%. So when we put a pulse ox on our finger and we're 99% on room air, that means that we are adequately oxygenating our bodies with 21% oxygen. Okay. If I tell you that my patient is on 100% FiO2, that means that they are requiring and receiving 100% oxygen. Not 21% like we are right now, 100%. So in order to wean a patient off of a ventilator, you have to get that FiO2 as low as possible so that your patient can get off the ventilator, and either most likely they will be on a nasal cannula after they get extubated. They can have supplemental oxygen. They don't have to be down to that 21%, but you cannot extubate a patient that is requiring 100% FiO2. So here is an example of a PF ratio. So our pH is 7.55. Our CO2 is 28.9. And our bicarb is 27.6. Our PO2 is 90. This marker is not working. Okay. So everything is falling over here, right? So we are not compensated, or we are what, partially compensated, right? Because the whole middle is empty. Okay, so we are looking at our PF ratio. The FiO2 has to be converted to a decimal. Okay, so in order to do that, you move the decimal point over 2. So if this was 32,327, no. Go back. I hate that this is doing this by itself. So, what am I trying to say here? I'm trying to explain how you make it into a decimal in the right words, but my brain is just farting out.
So you take 30 and divide it by 100. What
Thank
they have
you.
on there, 0.30 is wrong. It's 0.3. That 0.30 takes the number to the thousands.
You would never want to have a trailing 0, which she is completely correct. Okay. So the way I was thinking about it was like 30 out of 100, which is like, if you put that in a fraction and then converting a fraction into a decimal, my brain just like was not working. Ugh. But the point is that you divide the 98.2 divided by 0.3, and that's how you get your PF ratio, which is 327. Did I just confuse the heck out of you? And yes, you would divide the number by 100. 30 divided by 100 would be 0.3. So our interpretation, this is something you're going to want to remember. Okay, this is something you're definitely going to need for your test. If your PF ratio is greater than 100, you are adequately oxygenated. So is our patient adequately oxygenated? I'm sorry,
No.
greater than 400. Greater than 400.
I was
I'm
just
sorry.
gonna say, you said 100.
I said 100. I'm sorry. Greater than 400. So 300 to 400 is hypoxemia. 200 to 300 is ARDS. And less than 200 is critical respiratory failure. The mortality percent for ARDS is 27%, which is huge. Huge, huge, huge. The mortality rate for critical respiratory failure is 45%. So if our PF ratio is 327 and we're showing hypoxia, what do we need to do? We need to increase our FiO2. Okay. So we have a case study. Mr. Martin is 55 years old who presents to his PCP on a Tuesday. Go back. With complaints of a productive cough for 3 days with fever, chills, fatigue, and it began in the last 24 hours. So this has occurred quite acutely. This clinic has capabilities for X-ray, rapid lab tests, and simple IV infusions. His PCP hears coarse rhonchi in Mr. Martin's lungs and decides to take a chest X-ray. The chest X-ray shows right lower lobe infiltrates. What does that mean?
Fluid in the right lower lung.
There's fluid accumulation, mucus fluid accumulation in the right lower lobe. So the right lower lobe is probably white on his chest X-ray. His rapid flu swab is negative. Mr. Martin's vital signs are as follows. He's 122/73, heart rate of 102, respiratory rate is 26, temperature is 38.6, SpO2 94, weight is 105 kilograms. He's diagnosed with pneumonia and sent home on azithromycin. 2 days later, on Thursday, Mr. Martin still has the cough, fever, chills, and fatigue, and is now having body aches on and off and is short of breath intermittently. He calls his PCP, concerned that the antibiotics are not working. His PCP agrees and changes his antibiotics to amoxicillin. On Friday, Mr. Martin's wife calls his PCP again because he is struggling to even get out of bed and is very fatigued and feverish. She reports a fever of 102.9. The PCP tells him to come into the clinic. He arrives at the clinic 20 minutes later. I would have told him to go to the ER, but that's just me. So, our first round of antibiotics has failed. Our second round of antibiotics has failed. He is progressed from a manageable pneumonia situation to going into what? Acute respiratory failure?
discharge. Oh.
So there is consolidation in the bases of the lungs. It's white over here. And this is getting whiter as we go up. So this was probably what it looked like the first day, but now we're on the third day and we're getting worse. The white is getting heavier. So which nursing assessment should be performed at this time? What do we need? We already have vital signs, I think.
ABGs.
We need an ABG. They didn't really say what he looked like when he got to the clinic. So actually, we didn't get vital signs. We got vital signs the first day. So we need vitals, right? We need an SpO2. We need an ABG. We have a chest X-ray. Upon further assessment, Mr. Martin has bronchi throughout his lung fields with occasional expiratory wheezes. He appears pale and is lethargic. His skin is tenting on his sternum and his nail beds are pale. His vital signs are as follows: 108/66, heart rate of 116, respiratory rate of 30, temperature 38.8, SpO2 is 92% on room air. What diagnostic test would you anticipate the provider ordering? So what's happening in the first paragraph? He
He's
is
having
extremely
respiratory
dehydrated.
failure.
Gonna get a CT.
He's going into respiratory failure. He's extremely dehydrated. He's septic. Look at his temperature. He's 38.8. We need some labs, white count,
Blood
maybe a
cultures.
sputum, blood culture, sputum culture. Supplemental oxygen, of course, but that's not what it's asking. Oh, we just talked about this. What would be
Oxygen.
some priority interventions for Mr.
Like
Martin? So
oxygen.
we need supplemental oxygen. We need to get his fever down.
Antipyretic.
We need some IV antibiotics for sure. So Mr. Martin's PCP believes he is suffering from dehydration related to his fever and orders 1 liter of normal saline to be infused in the clinic before sending Mr. Martin home. This PCP is crazy. Mr. Martin's gonna die. The nurse starts a peripheral IV and initiates the fluid bolus, which takes 1 hour to infuse. What evaluation information would you, as the nurse, want to obtain following the infusion of these IV fluids?
Check his mailbox and check.
Listening to the lung bases, making sure it doesn't get worse.
Vital signs again.
I would do an entire respiratory assessment, skin assessment, vitals,
Neuro.
Yeah, for sure. Yeah. Urinary output.
Call 911.
Amen. Mr. Martin's infusion completes after hours Friday. So the medical assistant removes his IV, tells him he can go home and to call the on-call team if he has any concerns. Mr. Martin returns home and tells his wife he doesn't really feel any better. For the next 2 days, Jesus. Over the weekend, Mr. Martin continues to be more and more fatigued. His wife finally calls the PCP on Sunday, who says to bring him in first thing in the morning. On Monday morning, Mr. Martin arrives at his PCP, who can immediately tell he has gotten much worse. He repeats a chest x-ray to find diffuse bilateral pulmonary infiltrates. Both sides. Diffused
This
meaning
sounds like a
everywhere.
lawsuit.
This sounds terrible. This sounds like a
I'm like,
PCP
this
needs to
sounds
be
like
fired.
a lawsuit.
He repeats the chest x-ray. Yeah, Mr. Martin is sent straight to the ED. He should have been sent to the ED last week. Okay. What step of the nursing process was skipped? What impact might that have had on Mr. Martin?
The emergency
Okay, so
department was
let's think
skipped.
about our nursing process. ADPI. What is it?
Assessment, diagnosis, implementation, ADPI. I'm sorry. Planning,
So we have
implementation,
assessment,
evaluation,
diagnose, planning,
planning,
implementation, evaluation.
implementation, and evaluation.
I believe that the step that missed was evaluation. They implemented plans and then never followed up to see if he was okay. Because
Right.
when we get to that evaluation step, we see that whatever we implemented didn't work. That's when you go back and plan better, implement different things. Mr. Martin arrives in the ED where providers confirm the diagnosis of bilateral pneumonia. Mr. Martin's SpO2 is 88%, so he is placed on 4 liters nasal cannula, which equals 36% FiO2. Remember, room air is 21%. The provider writes the following orders, which are implemented by the nurse. Keep SATs above 92%. Repeat chest x-ray in 4 hours. We need an ABG, CBC, BMP, and blood cultures. Insert a peripheral IV ×2. Give 1 liter normal saline IV bolus. Albuterol nebulizer 2.5. Mr. Martin's blood gas results are as follows. So our pH is 7.3. So our pH is over here. Our CO2 is 58. So we're over here. Our bicarb is 26. So we're over here. So what is our ABG interpretation? Respiratory
Uncompensated.
acidosis
Acidosis.
Is
with
it uncompensated?
partial compensation. Because my middle is empty. When my middle of my tic-tac-toe is empty, it's partially compensated. Remember our ABG rules? Our compensation rules?
I thought that if one of a CO3 or PCO2 was normal, then it's uncompensated.
26 is normal.
Oh, 26 is normal.
Right. I thought the
CO3 is
COH,
normal.
yeah. I
How
thought
are
one of
you
them was normal.
being correcting me? I swear, okay. She's right. It's uncompensated. I saw 26 and I just, boom, it's over. Okay. All right. So our, O2 is 96. And our FiO2 is 36. 36 divided by 100 would be 0.36. $266.6666666. So I'm gonna put 0.7. 266.7. Okay, so on our chart, where we talk about the PF ratio, where does that fall? Arts
Cards.
between 200 and 300? No, right? Yeah. Less than 200. No, it's 266.7.
Less than.
Mhm. So that means we need to increase Mr. Martin's FiO2, right?
Yes.
Mr. Martin's condition continues to deteriorate. He is placed on BiPAP and sent to the ICU. The next day, he is still struggling to oxygenate, and the family agrees to intubate him and place him on a mechanical ventilator. He is placed on assist control, FiO2 of 100%, a tidal volume of 440, and a PEEP of 5. After 1 hour, a blood gas is drawn with the following results. We're going to get into the ventilator settings. So we have a pH of 7.25. We have a CO2 of 52. Bicarb of 28. Now we're partially compensated. Our PO2 is 90. Our FiO2 is 100. See if there's notes. That's what I was thinking. Okay. So our PF ratio is 90 over 1.0.
So he would be
Is
99.
he over oxygenated?
No. He's in critical
He's in
respiratory failure.
But he's
He is like, yeah, it's 90. His PF ratio is 90. So-
he's still
Oh, I get it. Okay.
Your number, not the SaO2.
okay.
PaO2, because now we have an arterial blood gas that's showing a PaO2. At first, all we had was the pulse ox.
Right. That
So
wife need to sleep.
if you're thinking about the stages of ARDS, where we were talking about the exudative, proliferative, and what was the last one? Last one was bad.
Fibrotic.
Fibrotic, thank you. There is so much injury that has occurred in Mr. Martin's lungs that his ability to oxygenate is practically gone, and he's on 100% FiO2. There's no more oxygen we can give you. It doesn't go over 100%. Okay, so let's see what happens next. We just talked about this. Let's see what Dr. Bowling has to say. Mr. Martin's pneumonia has caused an inflammatory response within his lungs that led to the alveoli filling with fluid and inflammation and scarring of the lungs. This leads to refractory hypoxemia, which we talked was a cardinal sign or hallmark sign of ARDS, or low oxygen that doesn't respond to an increased FiO2. This has made gas exchange nearly impossible, which is why he is in that critical respiratory failure. So, Mr. Martin is in the ICU for 14 days. He has multiple bronchoscopies to attempt to clear the fluid from his lungs. He was continued on high-dose IV antibiotics after his blood cultures revealed strep A pneumonia. His PEEP is progressively increased until it is at a max of 14. He is placed on lung protective ventilator settings to prevent barotrauma and promote opening of the alveoli. He remained in severe ARDS despite all interventions. He was too unstable to take to the OR for a trach and ended up going into cardiogenic shock. Despite all interventions, Mr. Martin passed away with his family by his side on the 14th day in the ICU. I couldn't tell you how many patients I have had this situation with, and withdrawn care on. The one thing I learned when I transferred to the ICU that I never really could grasp until I worked there was how many people don't leave the ICU. Because when I worked on a step-down unit, all I got was transfers from the ICU. But realizing how many people don't even make it out to transfer to a step-down was a lot. So, what would we have done differently?
You would have
So many things.
I would have sent him to the emergency department immediately.
So at the very, very first PCP appointment, would I have sent him to the ER? Probably not.
Yeah.
I would say at the second, when I knew the antibiotics weren't working. Right.
It's getting worse.
Both oral antibiotics were not working. My patient was progressively being more symptomatic. His chest x-ray diagnostic testings were getting worse. At that point, where both antibiotics failed, his symptoms were getting progressively worse. He is septic. His unilateral right lower lobe pneumonia has now infiltrated his other lung. Dude needs to go to the hospital. And that would we have ended up here? Maybe. We can't say, because every human is different. And even if he would have gotten early care, he still could have ended up here. But there was a way better chance of him surviving if he would have been evaluated after the implementation of their plan, and realized that their planning sucked and he needed more intervention. So what was his cause of ARDS? Pneumonia. He had strep A pneumonia. What are the main aspects of patient education for acute respiratory distress? So his cause was pneumonia, but there are a ton of other causes also, which include bacteremia, sepsis, trauma, pneumonia aspiration, drug overdose, drowning. So for patient education, We would want to educate the family on the severity of the condition and probable course. What's going to happen? The possible need for a trach. I mean, if he would have gotten early intervention and still progressed to ARDS, eventually he probably could have been a candidate for a trach, but he was so critical that there was no way he would have survived the OR. Possible, I mean, obviously possible endotracheal tube and ventilation, which should be definitely discussed before a trach. Recovery time, possible need for rehabilitation, and then infection control. So it sounds like it started with acute respiratory failure because it happened really suddenly, right? But then his care wasn't done properly, which then put him into ARDS, into the exudative phase, into the proliferative phase, and then unfortunately into the fibrotic stage where he was in critical respiratory failure with a 45% mortality rate. We have 30 more minutes. Do we need a break? Let's just power through. Good. Yeah. Okay. I'm recording. I'll send it to you. Will you sign up?
I do.
Okay, so next on the list, we have pulmonary artery hypertension. This is increased blood pressure in the pulmonary circulation. A normal mean pulmonary pressure is between 12 and 25 millimeters of mercury. And it's measured by a right-sided heart cath. Excuse me. With a pulmonary artery catheter or estimated with Indigo. There's two types of pulmonary artery hypertension. There's idiopathic, which is uncommon, very rare. It affects more women 20 to 40 years old, fatal within 5 years of diagnosis, and there's unknown causes. Oh. So the pulmonary artery hypertension results in the left ventricle receiving less blood. This causes compensation for the rest of the heart. The heart has to pump harder, it has to pump faster, and eventually it leads to heart failure where you have fluid building up peripherally within the lungs. I mean, it's just fluid buildup everywhere from heart failure.
Can you slide this, scoot the slide up so I can, thank you.
There it is. And then there's secondary, which results from existing cardiac pulmonary disease or pulmonary artery constriction disease. And the prognosis varies. Some causes include left ventricular failure, mitral stenosis, emphysema, thromboembolism, HIV, congenital heart disease, COPD, and portal hypertension. Portal hypertension occurs from the liver, from the portal vein of the liver. And it's just another type of hypertension. I learned yesterday that emphysema is actually a type of COPD. I didn't know that. So your symptoms are dyspnea, syncope, chest pain, loss of appetite, JVD, ascites, which is fluid accumulation where? From what? Liver. From the liver in the abdomen.
Liver.
Yep. Lower leg edema. Treatments include anticoagulants, thrombolysis, surgery, which are the surgeries are the pulmonary thromboendarterectomy, which means they literally go in to the artery to remove clots. An inferior vena cava filter. Diagnosis is chest x-ray, echocardiogram, electrocardiogram, a right heart cath, and there's 62 slides on here. What do you mean? It says 4 more pages.
This is end of day 1.
Oh. Ventilation perfusion scan. And then nursing interventions, watch closely with COPD, pulmonary embolism, and congenital heart disease, because these put the patient more at risk for this disorder. Oxygenation therapy, emotional and psychosocial support. So your main treatment is truly prevention in high-risk individuals. So we are now moving on to a PE. Pulmonary embolism. This is a blood clot that blocks a blood vessel in the lungs, usually the pulmonary artery, and it causes an obstruction of blood flow. So risk factors, of course, one of your number 1 risk factors is going to be recent surgery combined also with immobility. But they can be on their own, but combined, definitely very, very high risk for a PE. Arrhythmias, remember we were talking about AFib, and the quivering of the atria causes stasis of blood within the atria, which causes blood to pool and clot. So if you have AFib, you will be on anticoagulants unless contraindicated for the rest of your life. Remember me saying that? So if you're not, then AFib is a huge risk factor for clotting. Obesity, smoking, birth control plus smoking, huge, huge, huge risk. Oral contraceptives by themselves, smoking by themselves are risky, but put them together, you're doubling your risk. Long bone fractures, that can lead to a fat embolism. What is held within the long bones? Bone marrow, spongy, red and yellow bone marrow, where fat globules live. If you have a fracture of a long bone, that globule of fat from the yellow bone marrow can creep into your circulation, causing a fat embolism. But the most common cause is getting a DVT and that DVT migrating into your lungs. So the blood clot forms in one of the lower extremities. Also, by the way, a DVT can be in your arms or legs. Okay? Not just your legs. And gets dislodged, travels up the vascular system, and becomes lodged in the lungs. This impairs circulation and, of course, impairs gas exchange. So you see, there's this PE right here in the middle of the bronchioles. So it cuts off oxygen and blood flow to the rest of the lung tissue. Which is why a symptom of a PE, your first symptom is shortness of breath. Also, anxiety and a feeling of impending doom. Tachycardia, your heart is working harder to oxygenate. Tachypnea, you're breathing faster to get more oxygen. Chest pain with inspiration, because every time you try to inflate those lungs, you're not getting past that PE, that blood clot. Hypotension, diaphoresis, and sometimes a sudden change in your level of consciousness. Diagnostics include a CT scan, an elevated D-dimer, which is usually it's not 0.5. It's usually like hundreds. Like if it's over 500 is a positive D-dimer. It's not usually to the tenths like that. Another diagnostic test that can be used is a forget what it's called, P scan, PQ scan? I don't know, I'll look it up. Complications, if not treated promptly, it can lead to respiratory failure, cardiac arrest, sudden death, and cor pulmonale, which all of these require immediate intervention. Cor pulmonale is also known as right-sided heart failure. It is another term for right-sided heart failure. Medications would be anticoagulation therapy, which prevent the clot from getting bigger and forming new clots. Thrombolytics, dissolving the clot. That's not routine, using thrombolytics or a PE. It could happen. Procedures would be a thrombectomy, which is the removal of the thrombus surgically. And then an IVC filter, which is a inferior vena cava filter, which stops the clot from traveling into the lung from a DVT. So if you already have a PE, a IVC filter isn't really going to do much, because it really, the purpose of an IVC filter is to stop a DVT from getting to the lungs. It's like a little basket that they put within the vein, like a filter, like a colander, that if it were to go up the vein, it would stop right there in that filter. Nursing interventions include vital signs, assessing the respiratory status, anticoagulation, thrombolytic therapy. We would always, especially your patient is on anticoagulant, we would be looking for signs of excessive bleeding, bleeding gums, bloody nose, hematuria. What are the other signs of bleeding?
Just like in general,
In general, signs of bleeding. I mean, like nursing assessment wise.
Oh, bleeding.
Bruising, easy bruising, bleeding gums, bloody nose, hematuria, GI bleed, petechiae. Oxygenation, we want to administer oxygen as needed, reposition frequently to promote gas exchange, elevate the head of the bed. Truly, you want to prevent DVTs from occurring. Okay? So prevention is key. Early ambulation after surgery. Hospitalized humans need to get out of that bed. They need to ambulate. Okay? Range of motions exercises if they are not able to get up and ambulate. Compression stockings, and we don't want to cross the legs. Oh my goodness. After my mother-in-law got her knee replaced, that's all she did, cross her leg. I had to tell her, I'm not kidding, 25 times a day. Mary, uncross your legs. It's infuriating. Bleeding precautions, you want to make sure you use a soft bristled toothbrush. Electric razors, no razor blades. We do not want to take aspirin on top of our anticoagulants. And this is a huge safety concern. We are avoiding falls. Another thing that's really common, at least was really common at St. E's when I worked there, it's called an ECOS catheter. An ECOS catheter is a specialized heparin drip that actually helps with vibration to try to dissolve the clot. And they're on bed rest. If your patient is on a heparin drip, we're most likely not going to be ambulating them. We're most likely going to be on bed rest because we don't want them getting up, falling, and then bleeding out. Okay. That is the end of day 1. There's a lot of terminology that was included in that we have never gone over, talked about, and I want to make sure we correct that on Monday. Okay. Maybe I'll send out a glossary of terms. I feel like that would be right. I just feel like that would be helpful. It's like, what does this mean?
Scenario.
Shapiro?
Peep.
Peep. Peep is event setting. Peep is, hold on, because I don't want to screw it up. It has to do with exhalation. PEEP is positive end expiratory pressure. It is a fundamental component of mechanical ventilation used to maintain alveolar patency at the end of expirations. So, what happens when you inhale and exhale? The alveoli never actually fully collapse. They do kind of contract a little bit and then dilate a little bit when air comes in and out, but you never, ever, ever want the alveoli to completely collapse. And what happens with ventilation is there's so much forced air, forced inspiratory tidal volume that it will cause the alveoli to completely collapse. So what the PEEP does is the higher it is, the more pressure there is to keep the alveoli open. So the reason that you can't just keep going up and up and up and up on the PEEP is that it will actually cause the alveoli to just burst. So you can only go so high. And the higher you have to go with your PEEP, the more critical your patient becomes.
That's not testable, is it? Oh, thank God.
No, I'm not testing
Alright,
it on
great.
PEEP. It is important for you to know what it is, though, which is why I'm going to make you a little glossary of terms.
It's harder.
It's going to be great. For the math remediation, if you failed your math, you have to do the module. There is a math remediation in week 2 that you must do.
The night before our next test.
Please don't wait. Please don't wait that long. Listen, we already talked about this. I literally told you that I wasn't going to make you do the module unless you failed your math exam. If you failed your math exam, you had to do the module, and you were like, okay. Thanks, Jess.
We don't have to mention, none of us use it, it's useless.
First of all, the modules teach you in all 3 ways. Okay, well, I don't know what to tell you because if I would have had you a long time ago, I would have told you that you need to learn dimensional analysis. And if you don't learn dimensional analysis by the time you get to my class, you are going to struggle heavily.
Oh, no.
I literally told someone that last week.
Tablespoon's wrong. It doesn't give it my recipe.
Any questions, friends?
Do you know what Sylvania's doing tomorrow or who it's with?
I have an email about that somewhere. Hold on. Amy Freight, where are you? Amy is doing your VSIM tomorrow, and I am doing your VSIM on Friday.
Okay, perfect. Thank you.
You're welcome. How are my Niles people? You guys okay? Yeah. Was Mayana here today?
I'm here.
Oh, there you are. Listen, all I see is mountains, okay? Forgive me.
Sorry.
All I see is greenery and mountains. And then all I see at Fia, I see your Nurse Ratchet back there. She freaked me out earlier. She doesn't laugh. Why don't you laugh at my jokes, Fia? Can you hear me? No? She don't laugh at my jokes.
I don't think she can
Okay.
hear you.
How? I can't hear you. You're muted. I don't know what to tell you. You gotta unmute yourself, girl. All right.
Are we gonna get these slides before Monday? Like so that we can
Yeah, I feel like I should do that.
thank you.
Please do so I can start typing.
Okay.
Please
Yeah, I'm
so I can
looking like
finish
that's a lot
writing.
of info we didn't go over, and it looks dangerous. I ain't gonna be able to learn that in a day and a half before the exam. I need those slides.
I know. All right, guys. If you get an email from me or if you want to meet with me, I sent the link in the email. Bailey, did you mean to make 2 appointments? I don't know where she went.
Oh yeah, I made an appointment so I can go over the next test too.
Okay. I was like, I wonder if she knows she did that. All right, guys.
Yeah.
I will send that out. I'll send out the recording. And we will talk on Monday. I hope you guys have a good rest of your week and a good clinical days, and learn lots. Okay, I'll see you later.